We're excited to have you all here today. So my name is Jada Shapiro. I'm the founder of Boober and Birthday Presents. Boober is a platform where expectant parents and new families can find all of their pregnancy to postpartum care providers, like birth doulas, postpartum doulas, lactation consultants, and mental health therapists who specialize in pregnancy to postpartum, especially important during COVID, as a lot of the anxiety and concerns and questions has been running high. So we are here for you. We've always been a completely in-person company, but with all of the COVID-19 changes right now, everything is virtual, all of our care. So please reach out if you need anything. My other company, Birthday Presents, provides childbirth education classes and doula training. And we've been around in New York for 18 years and have served many, 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 many families, thousands, 20,000 parents. So I am so excited to have you all here. We also have some doulas here I see who've had home births as well. And I'm really excited to have Shawna King here today. I'm going to tell you a little bit, and then I am going to allow her to introduce herself. I also really wanted to thank Park Slope Parents, who's our media sponsor, and they really are an amazing community support for everybody. So when you're pregnant, you can stay after your kids go to college through Park Slope Parents. All right, so Shawna has been a midwife since 2002 and has had the privilege of caring for families from all boroughs and in a variety of settings, including hospitals, in-hospital birthing centers, freestanding birth centers, and most recently, home birth. She's dedicated her practice to providing evidence-based care in a personalized and meaningful way, while striving to form a partnership that empowers people to make informed choices about their bodies and their health, which is, I think, a lot about what we're here to talk to you about. So first, I'll just let you introduce yourself, Shawna. Thank you.
Hello, hi, everyone. You can hear me, Jada, right?
I can hear you, yeah.
Okay, awesome. Yeah, I'm Shawna, and like Jada said, I've been a midwife since 2002. I spent most of my career working in a hospital. I was at Mount Sinai East for 9 years, and then in a hospital-based practice with midwives and doctors in Brooklyn, and then most recently, I've been doing home birth. And yeah, and it's been an amazing transition out of hospital, and just a very interesting time to also start an out of hospital practice with COVID happening at the same time. But it's been a beautiful process to be able to support families at home.
Thank you. Yeah. So I think, with what we've really seen, of course, in our country, during this time of COVID, I mean, when I was first hearing about COVID coming from Wuhan, actually, and reading about it, the first thing I read something about pregnant people, and it just sparked in my mind, like, what's going to happen? Of course, in the US, this is coming, and what's going to happen? And I wrote a blog post saying, should we consider home birth for people who are the right fit for a home birth, right? Is that something people are going to be considered? I made that question. And some people were like, what? Why would you even bring that up? And then all of a sudden, as the coronavirus crept closer and as people started to be concerned, we saw, I think, right, a huge surge in interest all of a sudden in home birth, when we know right now it's only about 1% of Americans actually give birth at home and make that choice. So I guess first question for you is, did you have a huge uptick or surge in requests for home birth?
It really was like a wave. It was really interesting. The first people who came, and they were probably like you, starting to think, okay, look at what's happening in China. This is probably coming here. This is going to probably start to overwhelm hospitals and hospital staff. Maybe I want to be at home where I'll be, potentially safe from the virus and minimize my exposure from the virus. Then, and that was like a small beginning of people that maybe would have been thinking about home birth, but for whatever reasons had decided to go ahead and go with a hospital birth. And this was sort of the thing that pushed them over towards a home birth. Then we had this huge surge when the hospitals had the policy of no partners during labor. First, it was no doulas, you know, it was just one support person. So then ultimately most people are bringing their partner, not their doula. And then when it was not even the partners to come during labor, and when that happened, it was like the floodgates opened, and we were getting, I mean, as a group, we were, you know, getting hundreds of requests every week, and people that were just, you know, it was like the Titanic was sinking and everyone was just jumping off and trying to figure out where to land. And that was a really challenging time. It, you know, as amazing as it is, especially I was, you know, I'm building a business and I'm, you know, wanting to take people on into my practice, but then it's really challenging to have people, you know, most people who are seeking home birth at least know a little bit about home birth, but this was a time where people were just, it was like really afraid of what's happening in the hospital and wanting anything else, and potentially don't know anything about home birth. And so and that was also scary, because just because you're afraid of the hospital doesn't necessarily mean that then home is the right answer for you. And so that's when we really had to start to think about, how are we going to help this problem? You know, what's the answer to this? Because the answer is not everybody comes to home birth, because we know that that's not reality. We just don't even have enough home birth midwives to support that, you know, huge influx of families. So and we also know not everyone's a candidate for home birth. So we just had to really figure out what was our position going to be on this uptick in requests, and then also how are we going to help families that still needed to be in the hospital and to advocate for themselves, to push these hospitals to roll back that policy of no support, because really that was the most important thing. Like, hospitals needed to see that it's not safe to have someone laboring alone wherever they are, you know. And so, yeah, so that was really what happened. So it was an interesting time, and it was really concentrated to that first month. And I feel like now we're really settling back into maybe what was sort of happening in the very beginning. People who are choosing home birth for, you know, whatever their reasons are. Obviously, there's a myriad of reasons why people choose home birth, and COVID can sometimes be part of that decision making, but to be people back to where people who would have potentially been something they would have chosen, and now are looking to it, and that might be the thing that sort of pushed them to it.
Yeah, I mean, I guess that would be really helpful to hear. So if we were to kind of dial back the conversation for a minute and say, who is kind of looking for home birth? Like, let's even back up without COVID, right? What is kind of, when we say an ideal candidate, or what do you find are the qualities in a person, or you know, or their risk factors, et cetera, which makes somebody a good potential candidate for home birth? And we know that not everybody can safely birth at home. And so, you know, how do we keep home birth safe? Who would you discourage from considering?
Yeah. Well, I think that, I mean, somebody who makes a good home birth candidate is someone who's really motivated to be a part of their care, because that's really part of what makes home birth so unique and really such a beautiful process, is that it's really a partnership between the midwife and the birthing person and their family, because we're all, you know, working together to provide safe and thorough and compassionate care. And there's some responsibility that the pregnant person also has to take on, because we, you know, we're not here to make decisions for you. We're here to give you information and help you make informed decisions about your own health, your own body, and your own pregnancy. And so it takes a certain personality, you know, someone who doesn't, you know, that doesn't want to be told what to do, but wants to be a part of that decision making. And so that's, you know, I think that sometimes is really the most important thing, is the motivation behind it. And then obviously we're looking for people who are low risk, that are without, you know, medical history that would be complicating their pregnancy or their birth. it doesn't mean that you have that any previous history, because we have people that maybe, you know, you have a thyroid disease and you're on medication, but it's, you know, controlled with an endocrinologist. You know, this is somebody who could still be potentially low risk. So there's certain things that don't, you know, risk you out immediately, but it definitely has to be a conversation with the midwife who's planning on taking care of you and what, you know, that person feels comfortable with. Yeah. So, I mean, those are really the big things, is just that motivation and that desire to be a part of your care.
Right.
And then, you know, we're looking for people who have had either low risk pregnancies in the past, and this is now a low risk pregnancy, or a low risk first pregnancy.
You find it's more often that somebody comes to you having had a baby in the past, maybe in the hospital, or had a different experience and they want to try something. They had a disappointing hospital experience and they now, you know, want to have a home birth for that more personalized, empowered approach and that autonomy that you're describing. Is that more often than the first time person, would you say?
I would say that it's a mix, for sure. I mean, I think that there are the first time parents, which I think is amazing when you are coming to this decision without any previous experience and it's something that you're, you know, choosing for yourself. But then there are a number of people who, you know, went whatever path they went down the first time and then are realizing that, you know, they maybe want something more holistic, want something with less intervention. And, you know, and sometimes there was potentially a traumatic experience that happened before, not always, but sometimes, you know, for sure.
Yeah. And about what week would you say, like if somebody is seeking a home birth, you know, how many, for instance, how many patients can you take in a month? Are you currently taking people? We know that you said with this whole uptick, right, there were just such an onslaught of requests coming from so many different directions that we didn't have enough home birth midwives in New York City to even begin to consider taking on all those people, if in fact they decided that was really what they wanted. Right. So on average, would you say how many patients do you yourself take? How many in general do home birth midwives take?
I think everyone has a different number and what they're comfortable with, but I would say that we all keep our practices small, whatever that means for each individual practice. But the reason why we do that is because the level of care that we give, you know, and the length of time that we spend at prenatal visits, that, you know, how hands-on we are during the labor and the birth, and, you know, the number of postpartum visits we do. So there's just simply not, you know, we just don't have the time to take on more clients. I personally take on about 4 a month, and I think that that's sort of average. I know some midwives will take on a few more, and then definitely when there are 2 midwives in a practice, they're probably taking on more. But I would say that that's about the average. And I feel like that's a good number for me, just given, you know, just you're wanting to be present. And yeah, so that's really,
because you're actually, I mean, as a home birth midwife, you're present so much more, right? I mean, I've been a doula for 18 years and been to all sorts of different kinds of births. And I mean, to me, one of the big differences is how home birth midwives are really there with you, you know, you tend to be much more present in a continual way, not necessarily super early. It depends on what the client needs, right? But I guess I would love to hear that from you. What does that presence mean to you when you're working with a client?
Yeah. Well, I guess if I go prenatal visits, before all of this, we were doing in person, and a lot of the practices we're doing in-home prenatal visits. So, you know, when I was working in the hospital or in an office, I could see 20 to 25 people in a day, because I would be scheduled, you know, 15-minute prenatal visits. And you just power through them and get through a day. Now, if I do 3 prenatal visits in a day, it feels like a lot, just because if I'm having to drive to each of the places and, you know, I'm spending an hour with you and there's a lot of follow-up. And so it's a different kind of care. And especially for the birth, I mean, we are either on the phone or texting from, you know, very early in the labor process. Even if we're not physically there, there's a lot of conversations, you know, leading up to when we arrive, and then we're staying after the birth for a number of hours, coming back the next day. So, you know, each labor and birth takes up, you know, it might take up a week of your time, because you're going back for the prenatal, for the postpartum visits, you're checking in with the mom every single day about how the baby's doing, how the breastfeeding is doing. And so, you know, it's all time intensive, but it's really beautiful, deep, intimate work.
Yeah,
You
no,
know?
I mean, I think that's one of the most amazing things. I mean, I think would love to hear from you, just for the community out there who's kind of curious about home birth, right? What are some of the benefits, really, then, that as we're continuing this conversation, that you see for the right person, and just what are some of those things that you really love, since you've worked in every kind of environment? What are the things that really stand out about home birth to you?
Yeah. Well, I think just even back to those prenatal visits, how I described how I was having to do prenatal care in the past, where I would have 15 minutes. And now I can't imagine only have 15 minutes to talk to somebody about their pregnancy and how they're feeling and what they're eating. You know, we go into a level of education and conversation that it's really hard to get in a hospital-based practice, just because you have the time constraints and the schedule constraints. And what's beautiful when you're when you have your own practice, and especially it's a home birth practice, we a lot for that amount of time, because we know that it's really important for people to be informed and to give people the space and the time to talk about these things and to talk about the pregnancy. I don't want anybody to feel rushed. And, you know, and that was also part of why it was also sometimes challenging for me when I was working even in the clinic setting or the office setting, is that, you know, I inherently was always behind, because I was always talking more than, you know, trying to get all that education in, and that 15 minutes was impossible. So that's what's really beautiful about the prenatal care. And then, and you really, and it's also important, because then you're forming that bond, and that trust that's so important when you go into the labor and birthing scenario, right? So you need that time to develop that trust, so that you have that relationship. When you show up at that person's birth, they're going to trust your decision making, and trust that you're going to be keeping them and their baby safe. And so, and that's why that's so important. And you did ask me about when people come into the practice. And although, I mean, I would say most of the practices would be open to taking late transfers. Part of the problem with that is most of the time our practices book in advance, and, you know, sometimes months in advance. So even if somebody tries to come to a practice later in the pregnancy, there just may not be room in that practice for them. But you know, ideally somebody's coming as early as possible in the pregnancy, so that you have time to build that relationship. That doesn't mean to say we won't take people later. It just means we have to fast forward and really try to get it all in, you know, in the time that we have. But ideally somebody's coming earlier in the pregnancy.
Yeah. And how often, you know, let's talk about some of the big differences. Obviously, I mean, there's pretty obvious differences, I guess, between home birth and hospital birth. But would you say at a lot of your home births, or home birth in general, we see a lot of people, you know, renting birth tubs, for instance? Do you deliver in the water? Is that an option for your clients, patients?
Yeah. So I think that, you know, anytime we're talking about home birth, we're talking about focusing on a healthy physiologic birthing process, right? So we're encouraging people to eat and drink in labor. We're using interventions only when necessary, when there's some sort of complication, but otherwise we're really, you know, staying away from unnecessary interventions, allowing somebody to live freely by doing intermittent monitoring. So we use the Doppler to monitor, so that someone's not hooked up to something. We're engaging oral hydration, drinking and eating so that you don't need an IV and so that you don't have to be hooked up to the IV too, so that you can move around, find positions that are comfortable for you. And these, you know, just those two things are really hard to find in a hospital setting. Most hospitals, you know, want you to be, well, those are, I guess I said three things, but, you know, want you to be, have an IV, want you to be connected to a monitor. And, you know, some hospitals still, even though there have been recommendations where women should be able to eat and drink in labor, are still not allowing people to eat and drink in labor. You know, so
Yeah. I mean, it's
just the, you know, the, yeah.
the real desire on a lot of people's part, I think, to move to home birth is that you know, ability to safely practice, have a birth where they're not trying to not have interventions. I think that's what we want to communicate to people. It's that if intervention is necessary, then you take those steps, right? But that you don't routinely apply that to each person.
Yeah. Yeah. And that's part of that individualized care. We don't have protocol, you know, maybe there, you know, there's some protocols that are for everyone in the practice, but I would say most protocols are individualized when needed. So I bring what I need to start an IV. If someone is dehydrated or IV antibiotics for GBS, I have those things, but I'm not giving everyone an IV. I'm giving someone an IV that needs the IV.
Right. I think I disappeared for a minute. Can you hear me?
I lost you.
Okay. We'll just wait a moment. I'll be back, everyone, in one moment. Let me know when I'm back.
Sorry.
Hi, I think I'm back. Am I back, everyone? Can you hear us again?
You're back. You're back.
I'm back. Okay. Yeah, there's a little choppiness coming through and I can't tell which of ours it is, but I don't know if that's coming, but I can mostly hear everything. So I think I'm back. So sometimes that happens, everybody. All right. Right. So, yes, great. So great to hear about that. I mean, let me drop two questions here that have come in from people. You know, one person, I think this was, we had some pre-questions and then some that are coming in. And this is just a practical question from somebody. And I love this question because I get it a lot as well. When people are considering home birth, but what do I do about my neighbors? Like if I'm thinking about having a home birth, but I'm afraid of the sounds I might make, you know, do you have standard recommendations that you give out if somebody is worried about that? Because we're living in a tight, small city.
Yeah. I think that it really depends on who your neighbors are. If you feel comfortable telling them in advance or even the day of that, you know, you're planning on a home birth, then I think that that's fine. I know that some families have put a little sign on the outside of their door or even slip notes underneath the neighbor's door just to say, you know, we're having a baby in apartment, whatever. I've had other families who haven't told anyone. And then, you know, I was leaving to put the trash out or something, and the neighbor was like standing there with her ear to the door, I think trying to figure out what was going on in there. So, you know, it's probably best to tell people in advance, but, you know, how far in advance really depends on your relationship with your neighbors, and maybe just the day of is fine, you know.
Totally. I agree with that. I mean, I think you should tell your neighbors by the time it's happening, just because some of the sounds we do make, if we're feeling free in labor, we may make wild sounds that could prompt a neighbor to actually call the police, thinking something else is happening, not even realizing a baby is being born, right? And we would not want that. And somebody actually also did ask the question, is it legal to have a home birth in New York? So, you know, I'll let you float that.
Yeah. Yes, it is legal. In New York State, we have a pathway for licensure for midwives. All midwives that practice in New York State are licensed through the state and certified through the ACNM, the American College of Nurse Midwives. And so that's how we practice, and we have certified nurse midwives and certified midwives we're all under the same umbrella as licensed midwives in New York State.
Yeah, thank you.
Yeah.
And somebody also had a question, just we'll pepper in some practical questions. How do you plan for an older child? You know, how would you be able to tell that your kid can handle it? Do you have any advice for people who are thinking about having their older children there?
There are a couple of really good books for older siblings about home birth, which Penny Simpkins, I think, has a book. And then there are also some or maybe she has I think there's maybe a video and a book. And somebody made the suggestion to me the other day, which I thought was really interesting, was to maybe watch videos on YouTube of animals giving birth.
Yeah.
And you know, and that maybe see how your child reacts to that. I've had older siblings that have been very involved in the birth before, and I've held older siblings who just stay in their room with the door shut and just want to come out when the baby's born. And so I think that it's just about your family, and you have to, you know, really just figure out what's going to be right for your kid at the time. And you know, sometimes at night, if everybody's sleeping, then, you know, the older siblings will stay asleep, hopefully, and then maybe you wake them up when the baby comes, you know, and during the day, I guess it's, you know, it's a little different. Sometimes go somewhere else too. I mean, I've had where the kids will go, you know, to a family member's home because the parents are maybe feeling like it's not the right situation for the kid to be there. So I think that each family deals with it a little bit differently.
Yeah, definitely. There is that one amazing film, which I'm trying to remember the name of, which has the mom who is a midwife who gives birth, and then her children jump into the birth pool one after another after the baby's born. And I all of a sudden can't remember the name of it, even though I've seen it 1,000 times. It's beautiful. I'll try.
Yeah.
Yeah, but I think it is really individual to the family, and it's really actually almost more about the birthing parent and what you're feeling like. Do you have to protect the child, and are you not going to be able to let go and do your own thing, right? So a lot of times I find people bring family members to be there to either take the child out or to do something with the child in another room, not appropriate. And then a lot of times they want to creep out at the end, you know, so.
Yeah. Well, and I've had it where we've had to figure out a way for the child to leave because the birthing person, you know, parent was having a difficulty like transitioning into the labor process because they were too worried about caregiving, you know, especially if they're younger kids that are there, you know.
So a couple more questions coming in, and of course something that I have on my list to ask you because it's really important to consider, you know, obviously part of the way, or I shouldn't say obviously, to me, because I've been in this, part of how we keep home birth safe is because you're able to be monitoring and screening during a home birth if something has changed in the situation in the birthing parent and with the baby, you know, that you may need to transfer to the hospital, which becomes a safer option at the time. So a couple questions, one in light of all of the articles, there have been so many articles about COVID-19 and home birth and this uptick, and then we saw some stats that were clearly erroneous about how often labor transfer is. So I would like to hear how often, at least in our region, you know, about what is the transfer rate? How often does somebody move to the hospital ahead of time or during the labor? And then on top of that, can you talk to us about what kind of things, you know, would come up that might make us need to transfer?
I don't know where the 50% came from because that's not really a current reality for what happens in New York City. I think collectively the transfer rate is probably about 10%. And that's for first time you know, pregnancies and births and otherwise. I think, you know, probably it would be interesting to sort of separate out that statistic to figure out like what's really the transfer rate for a first time birthing person and for somebody who's had a baby before, because the emergency transfers for complications tend to be our rarest transfers. Those tend to be things, you know, if we're talking about fetal distress, if we're talking about, you know, hemorrhage, or if we're talking about blood pressure issues. I mean, what I would say is interesting about all of that is we usually have a sign that something is coming. And that's what's so important about, you know, if you look at any studies that have been done about home birth, that what makes home birth safe is when you have a qualified and skilled provider there with you, right? And so you want to make sure that you're choosing the person to be at your birth that's going to be looking for these signs throughout the laboring process. Is my baby in distress? By listening to the heart with the Doppler, you know, is that bleeding too much? You know, someone who's had experience with how much bleeding's too much, someone who has taken your blood pressure and knows how to monitor and what things to look for that are a problem with blood pressure. Those are some potential things, but those tend to be our rarest things that we transfer for. Most of the time, we're transferring in first labors that are potentially long or a little stalled, that need some extra help. So either somebody needs some augmentation, or maybe needs some pain management. And I would say that would probably be one of the bigger reasons why we transfer. And that is not an emergency transfer. That is, you know, something that we would be considering, you know, potentially a complication that would require being in the hospital, but we can do that in a non-emergent way. It's not a 911 call. You know, we figure out what hospital we're going to based on what borough we're in and how we're going to transport ourselves there.
Yeah, I was debating whether I'd bother, but talking about myself or introducing it a little, but I am somebody who did plan a home birth. I have a 12-year-old, and I labored at home for 31 hours and ended up transferring in a non-emergent way, but with creeping blood pressure. And that was one of the reasons, you know, and of course a pretty slow stalling labor, and was able to have a vaginal birth in the hospital. And we transferred to a hospital that was very friendly to home birth, because as somebody else here who wrote in as a physician who's considering home birth and had never thought they would consider this before, and wants to understand what are the contingency plans as we're starting to talk about reasons to transfer, you know, I think it's really important for people to understand what the whole process of the backup planning is. And I think I wanted to share because I remember my midwife introduced me, you know, I had to meet with her backup OB, and that was really important. And I had a relationship, I know that doesn't always happen, but I had to meet this person once. And I remember the OB telling me, I hope never to see you again, you know, but there are reasons why you might, and we keep home birth safe because we are working collaboratively. And it was really interesting. And I got to meet this person who, in the end, my situation did not warrant meeting the OB. I actually then transferred to this hospital where another midwife, you know, was able to take over the care with the OB being there, but I didn't need to see him. So, you know, and I knew I would have had a cesarean birth most likely based on how slowly my birth was not propelling, you know, and it felt to me after many years of being in the hospital and seeing how things were done as part of what motivated me to seek a home birth, because I really wanted to know that if I had to go to the hospital, it was because I had to go. And I trusted my midwife would take me. And when I knew it was time to go, like it was time to go, and that she wasn't going to let me stay, even if I insisted that I wanted to stay. So it was really, that was interesting. I'd love to hear how you work with backup.
Yeah. And so I think that it's less common to have that one-on-one relationship with an OB anymore, because we used to have language in our regulation that required us to have what's considered a backup physician, and that's now not part of the regulations to practice as a midwife. And so, but I think that's what has been really important for the home birth community and the collective of home birth midwives, is that we maintain good standing with hospitals in the city. And so we're very transparent about our transfers. You know, we call ahead of time to let them know that we're coming. We give a full report. We send over our charts ahead of time so that they can look at what, you know, who we're sending over and the history of that person. And then pre-COVID, we were also going to the hospitals and then being with our clients in the hospital when that was allowed as the second solution. And so I think that that also, in a way, provided that continuity of care, not only for the client, but also then for the hospital, that it doesn't feel like we're just dumping somebody on them, but that we're really, you know, we're making a decision, which if you know, we're making this decision that what is going to be the safest, and now we need a change of venue for this birth, and that, you know, and that this is what is now going to be safe for them. And so you're not going to get everybody on your side with this sort of thing, you know, but I feel like overall we've had really good transfers. We have good relationships with the hospitals that we transfer to. We tend, you know, in an emergency, and this is something that we talk a lot about during the prenatal care too, is really just formalizing the transfer plan. You know, where is the closest hospital? Where would we go if it was an emergency? And then talking about in non-emergent situations, when we can, you know, when we have the luxury of a little bit of time, and then maybe choosing a hospital that's friendlier to home birth transfer. So we talk a lot about that. And so, you know, in each of the boroughs, we've sort of figured out what that looks like, and, you know, where we would potentially transfer in these more non-emergent situations. And then obviously in emergency, we don't really have a choice. We go where it's the closest.
Yeah. Thank you. And I think another question that comes up a lot, and I really want to address in, you know, in terms of is insurance, right? Somebody wrote in today, and it has come up many times as we're talking about this. You know, what hospital charges are covered? What are, you know, between midwives and doulas and all of that, and income based, and especially now even more. I mean, do home birth midwives, does it cover insurance? Is home birth covered by insurance, I guess is the question really. And what about if it's not, how do you work with, or what options do people who can't afford the out-of-pocket prices? Yeah.
Mm-hmm. So all of the home birth midwives in New York City are out of network for insurance companies. And so essentially, it's not that we do or don't take insurance, it's just that it really depends on what your out of network benefits are and what the coverage is for home birth. There are actually a couple of Medicaid plans that pay very well for home birth. And so some of that is contingent on when you come into the practice. And so the earlier that you seek care, the more they'll pay for the pregnancy and birth fee, you know, more of the fee that they'll cover. And so, you know, that I think is very encouraging. If people are coming earlier, we also help to guide them. If it's somebody who maybe is on one of the Medicaid plans that doesn't pay as well, if they come early enough in the pregnancy, we work at the biller who can help them switch to a better plan that will provide coverage. We all, I mean, I'm going to speak for the group, I'm assuming that it's true, but we all work with biller to handle this, because the insurance situation is, you know, complicated at best, right? And each plan is a little different, what they cover, what the out-of-network benefits are. you know, what pre-authorizations have to happen, all this stuff. So we work with billers who this is their job to do that. So we want to make home birth affordable. I never want anyone to say I didn't have a home birth because I couldn't afford it, especially, you know, someone who's a good candidate and who's really motivated. We want to figure out a way to make it affordable for everyone, you know. And so, and I think each practice has their own way of handling that. I mean, as far as I know, everyone, you know, has some process of, you know, potentially reducing fee if that's something that is needed. You know, we just, you know, that's on a case by case basis. But I think that, you know, there definitely has been a, you know, I feel like people, I've heard people say a number of times, like, oh, I didn't have a home birth because, you know, you don't take insurance and it's expensive. And that's heartbreaking for me. You know, I didn't go into this, you know, to only provide service to people who can, you know, have the best insurance and who, you know, have all the money to throw at it. You know, we really want to provide it to people who are good candidates and who are really motivated. And, you know, I think that, you know, I know some practices that are really flexible in their pay schedule. And yeah, so I just think if finances and insurance is a question, it's always good just to reach out to the individual practice.
Thank you.
And if one practice is not willing, you know, don't stop there.
Yeah.
There's probably somebody else. And sometimes some, you know, some of the newer practices that are building, you know, their practice, you know, it might be somebody who's willing to, you know, make some sort of sliding scale or payment.
Thank you. So just a couple more questions before we let everybody go have their, I think it's Friday night. It's hard to tell what days are anymore. I am wondering how COVID-19 has impacted how you practice in general. Like, people have questions about, are you using protective gear? Are you using PPE? Can you tell us just how the prenatal visits are a little different, and how you are using, if you know, gear differently, if at all? How is that?
Yeah. So one of the big changes has been that we've been doing a lot of virtual prenatal visits. And so we are doing in-person visits for the essential visits, or any visits that need blood work done, or any testing. Then I'm in person for those visits. And the last month, I have a few, you know, I'm in person more just because we're you know, talking about the birth and planning for the birth and checking baby's position. And so those all require sort of being hands-on and in person. That changed a little bit because we're used to having all that time together. And so that time, some of it's, you know, via Zoom, but then some of it's, you know, one-on-one. And then to just minimize the amount of time that you're exposed to me being into your home, doing part of that in-person visit even virtually. And then I come in, I check the baby, listen to the heartbeat. Almost everyone has their own blood pressure cuff now, so that you've already taken the blood pressure and I know what that is. And so it's really just that quick belly check, coming in a mask and gloves and lots of hand washing at each visit. And then for the birth, a lot has changed at the birth, but I feel like now we sort of have our procedure down for how we're doing it. It was really a process to try to figure out what was going to be the safest for everyone. But we do, you know, we all are wearing N95s at the birth, you know, lots of gloves and hand washing. Also, we're minimizing all the extra stuff that we're bringing into the apartment. So like coats and personal stuff, you know, we're kind of limiting that. So just bringing the essential items for the birth. We're not wearing the hospital gowns, but we do have our own, it's not scrubs, but it's kind of a one-piece coverall that we wear over our outside clothes, so that then that's just specific for your birth. I take it off before I, you know, put it in a and then go home and wash it. You know, so we just want to make sure that everything that we bring in has been washed and cleaned prior to arriving to your home. And then, you know, we're cleaning and disinfecting all the instruments before we leave. And so, I mean, that's really been most of what we're doing for PPE. You know, our families that we're working with, most of them have been quarantined since the beginning of this, working from home. So have had minimal exposure. Really, the most exposure is us coming into their home because, you know, we're going out and seeing other families. So we really minimize how we expose them and just make sure that we're being as safe as possible. You know, so, you know, that's really what's happening.
And are you seeing doulas coming to the births in person right now or virtually? And if doulas are coming, you know, are you asking them to wear complete PPE? How are we dealing with that?
Yeah. So I've had doulas coming. I have had doulas in person. If someone has hired a doula, the doula has been coming in person. Usually what I've requested is that we have contact before the birth so that I can confirm that the doula has the PPE that she needs. You know, at a minimum, you're going to need your mask and the gloves. And so I have extra, you know, if there was a doula that needed that, I would bring that along. But doulas are coming, you know, in their mask with their gloves and, you know, following the same procedures as us. Lots of hand washing. Yeah, so that's really what has been happening.
Thank you. And I have two more questions because I want to make sure I get one from the other person. They just asked, can you please clarify, you know, is a CM and a CNM who have different, you know, the credential, is one more safe than the other? Do you feel, can you just address that? That was their question.
Yeah, excellent. So in New York State, CMs and CNMs are trained right next to each other. We go to the same school, we go through the same clinical rotations and the same training. So essentially our license is exactly the same. It's not required in New York State for you to have gone to nursing school before going to midwifery school. You do have to have some sort of health science background, so have taken the prerequisites, but you don't have to be a nurse. And so, and also a lot of the nurses that, you know, I went to school with, you know, had never actually even worked as a nurse and had gone through the schooling, but then were doing that to become a midwife. And so I think in the end, we're really, you know, the training is equal, the preparation for being a midwife is equal. And so I would say equally as safe.
And actually, I just realized the question also included and direct entry midwife.
So direct entry is different. We don't have a licensing pathway for direct entry in New York State, but there are other states that do. And that is an apprenticeship training usually. So this is someone who, you know, apprentices another midwife for some amount of time, some number of births, and then can be licensed. And I can't, and they have to take an exam. I don't know that pathway fully, so if I've misspoken in some way, please don't come at me. But you know, it's a little bit different in how they get to licensure, and so I think that it would just be hard for me to say if one was more safe than the other, because it just, I think it really comes down to the individual. You know, I don't necessarily think that one is more safe than the other. It's just really how, you know, each individual midwife you have to look at.
Right, which is, I think, always the case as we're choosing our care. And for many of you here who are debating home birth or being in a hospital if you're due later in the year, or maybe you're not even pregnant yet and you're just considering this option, I think, you know, so much about this is doing the research and meeting the people, meeting the care providers, asking the questions, checking in with yourself about what feels right, looking at the research, talking to other people about if they worked with those particular care providers as well, and then coming to those conclusions, right? Oneself. And I guess that's my last question for you is, you know, with all the attention toward home birth that there's been so much, whether or not people are considering it or doing it, but even just the talk of it has really brought home birth into the forefront. And I'm, you know, curious if you think there is some opportunity or something that is going to happen where we might start to, I mean, I guess since I became a doula 20 years ago, it became pretty clear to me very quickly, like, why don't we have a facility that's not in the hospital, but could offer you an epidural or a cesarean birth if you needed it, right? So without forcing you to walk through this location or place that is full of sick people. And I think that's really come to the forefront. And I think, you know, Governor Cuomo had something to say about this yesterday as well. But I'm curious if you think this conversation about home birth and midwives in general is going to shift.
Well, I think what's interesting, because we've had to really pare down what we do, that we're seeing really what is essential, right? So even the number of ultrasounds that get done in pregnancy, it was like all of a sudden, oh, maybe you don't actually need all of those extra ultrasounds. Those are maybe not the essential ultrasounds. And so I think in a way it's making us all think a little bit more about what is really essential, what is really safe, what's required, why were we requiring all of that before. And so, and I really felt like even when there was such that huge turn and that tidal wave of people looking into home birth that would have never looked into home birth before, you know, I probably had 50 conversations in 2 weeks with people about home birth. And even if they didn't ultimately choose to give birth at home, this was an opportunity for education, because everyone wants to ask kind of the same questions, like, is it safe? What happens in a transfer? What's going to happen with my baby? What do you bring in your bag? You know, and so I think that, so it was a way to really get to, you know, just talk about home birth very candidly. And I think that people are realizing that hospitals are great places, you know, to go when you're sick, but when you're well, maybe there's some place else for you, you know, and maybe the sick and the well people shouldn't be in the same place, you know. And I'm hoping that that starts to shift what happens in our maternity care.
Yeah. Well, thank you so much for being out there and working every day with our families and taking care of babies and birthing parents and new families. We're really, really grateful that you're out there doing this work. And thank you so much for coming to talk to us. So everybody out there, I might be frozen, but I wanted to say, I don't know if you can hear me, but thank you, everyone. Am I back? Can you hear me? Okay, you can hear me. That's good. But
Sorry.
I couldn't tell I disappeared. But thank you, everybody, so much for coming. We really appreciate it. Join us for our next webinar is about lactation next week. So we'll send that out there, and really appreciate everybody coming out to listen.
Thank you. Oh, I went away.